Morning and welcome to my YouTube channel, Pain Free Partha. Subscribe and listen to 80 odd number of videos in anesthesia and critical care and pain. Today's topic is about anesthesia for PCNL, percutaneous nephrolithotomy. Wishes from our institute, Mahatma Gandhi Medical College, Sri Balaji Vidyapeeth, Pondicherry. Now, what is this actually? It's a technique used to remove certain stones. It's a technique used to do, it's a percutaneous nephrolithotomy. So you just break down the stones and remove by a percutaneous endoscope. This is the basic thing that we do in PCNL. It was explained in the 1950s, and in 1976, Felstorm and Johansson did a nephrostomy and removed a tube. And now it's fast picking up PCNL. Indications of PCNL are large size renal calculi, staghorn calculi, upper tract, lower pole stones. It's very difficult to sometimes other modalities of treatment. Sometimes ESWL will not work. Cystine nephrolithiasis, stones in the anatomically abnormal kidneys. So large size staghorn calculus. These are the two common things which we encounter. Sometimes it is, here you can see lower pole, staghorn calculus, ureteric pelvic junctions, abnormal kidneys, all these things are indications. Now the contraindications are pregnancy and controlled urinary tract infections, non-functional kidney. Why do you want to remove stones? Remove the kidney. Now we will go to anesthesia considerations. Routine checkup should be done for all cases. For example, any history of previous surgeries, any history of previous systemic illness like diabetes, hypertension, all these things should go. Now, what we need to look into it is this, the simple tachycardia. For example, patient is on hypertensive, on beta blocker. You just see the rate is around 95. You be aware that there may be some sepsis. Deranged renal function, creatinine, urea is on the high level, 1.8. Kidney is okay or not? Is the other kidney okay? And CT abdomen, especially if there is any previous scars. So what we need to do, other than RFT, is hemoglobin, blood grouping, electrolytes, total count. If you also want to know, you can check it as a urine routine and see any pustule cast is there or not. Size of the stone is quite big. Size of the stone, lower pole, upper pole, anatomy of the kidney, where we are going to insert the scope, below the ribs or above the ribs. All these to be discussed with the surgeon. There are a lot of anesthesia techniques. Now we know preoperatively what should be our focus is where is the site of incision, where is the site of stone, is the normal kidney, is there any deranged renal function, is there any sepsis, hemoglobin, and what are the electrolytes. These things has to be focused rather than routine cardiac neuro nephro. So these things to be focused. General, epidural, spinal, local, all have been described. Now we will go to general anesthesia means because it is most commonly done under general anesthesia. We need to induce in the stretcher and put it back. So the stretcher may move sometimes. Stretcher will not have get down, get up positions. Stretcher, the intubating positions may not be very ideal. So now we know sometimes the monitors will be on the front side. As soon as you put in the positions, the electrodes have to be changed. Sometimes choline fasciculations will change the patient and the structure will move. So all these things should be taken care of when you start your GA in the stretcher. Now you see the stretcher, the patient's intubation is done. And now you see the intubator and the monitor also are removed. And here we can put it here. There are a lot of sponges. And you see is ready for prone position into the operating table. Now it has been put in the operating table. Now you see the knees, the legs, the hip, the chest, Abdomen is free, and there is cushion padding for the upper limbs, eyes, and ears. So these are all the routine things of a prone position. So we should be ready to write at least 5 points about prone positions and its problems when you deal with PCNL anesthesia. So here padding, chest and hip, abdomen is free, ear padding, eye padding, and arm padding. The people will use armored tubes. Fixation is very ideal as soon as, because change in position always. Fix the tube properly, gauge the length, memorize the length. Position change and accidental removal of IV lines. Blood from disconnected IV lines. The IV lines will get disconnected and blood will be pouring another 20 ml. Everything is soil. Plan your ECG electrode sites. Secure the tube. Disconnect the circuit for 1 to 3 readiness. Track. Push the patient into the operating table. Pads ready, chest up, recheck lines, endotracheal tube. Very important. Now, as soon as you pick the position, check up the endotracheal tube position, properly fixed. Airway pressure is fine. Saturation is fine. All these things. Next one, you should do all other things. As soon as you paint an insertion of the endoscope, nephroscope, to have the lung down. Now we see prone position. Already we have told the paddles, eyes protection, chest bolsters, knees, arms erected, abdominal compression, jugular compression is to be taken care of. The approximate absorption is 700 ml average per PCNL. Normal saline, water, glycine used. Water and glycine associated with hyponatremia. Even in chronic renal failure, normal saline wash was found to be safe. So proceed with NS. Potassium, hemoglobin will fall. Yes. Hemoglobin and transfusion should be gauged only after the correction of dilution factor, because you have given 700 ml. Extubation, sometimes people will put it back to the stretcher and take out the tube. But ready for supine conversion. Extubation can also be done in the prone. Keep the stretcher and then take it out the tube in the prone position. Shivering post-op, yes, very important. Shivering BP fall will come in many patients because of, as soon as you do technical with the stones, there will be bacteremia. So you will get shivering post-op, and check for BP, pulse, tachycardia, all these things when you get shivering. Don't correct administer tramadol, etc. So shivering is maybe due to bacteremia, and check for vitals, total count, just in the post-operative period. It's very important. Yes, sometimes people have now started to use a modified supine position for PCNL. This is a big advantage because all your problems of prone, intubation, extubation, position, stretcher, everything is normal. And the more obese study, the larger stones, reduce operating time, easy to learn. First, it is very important. Sometimes if you do a supine PCNL, sometimes you can put a stenting from there also. You can work from the supine position also. If it is prone, it is very difficult to work. We can try regional. No stretcher, intubation, no transfer. Need not worry about neck, eye, other injuries. Accidental extubation, nothing. Supine PCNL under GA is possible. Supine percutaneous nephrolithotomy in children have been done. Less chance of hypothermia, fluid absorption, easy monitoring. There is one more position called split leg position in prone. Secured independently, the genitalia are positioned at the bottom of the operating table, making room for retrograde access from here. That is the advantage of the split leg position. Sometimes we can take out the Foley's and do something from here. Bart's position is two supine, two pillows, two lithotomies. One leg is flexed, another is abducted. This is modified Valdivia position. Supine, one leg is lifted. Rigid ureteroscopy seems to be ideal in position. Ureteroscopy may be ideal in this position. Lateral decubitus, lateral flexed. morbidly obese, difficult to prone. Sometimes we can put lateral positions. Need to induce in the table and not in the structure if you have a supine position. Lithotomy, then stenting, then they will go back to prone in sometimes. Put a GA in the operation table only. Then they will do the lithotomy position. Then put the general anesthesia patient into the structure, ready the table and make it prone. This is also possible because they may do some ureteroscopic procedures, keep the stent, and then put the patient back to prone and then start PCNL. Now there are a lot of things, micro, mini, macro, so many types of PCNLs. Equipment advancements, smaller sheath size. But we cannot do big stones, and sometimes the time needed to cut these stones may be more. Monitoring depends upon renal functions. Normally, SaO2, ECG, NIBP, airway pressure, very important airway pressure. I will tell the cause later. Urine for color volume, bilateral air entry, fluoroscopy. Postoperative monitoring should continue to detect complications. Here, an intraoperative problem for the surgeon is they will introduce the scope and see the TV. In between, they will remove and put the C-arm and see the TV. So, for the surgeon, both the TVs should be near, which will pull the, which should be pulled. Sometimes difficult for the anesthetist and monitoring. Spinal with 3.5 ml bupivacaine and shift to prone. SA is as effective as GA. Patients who undergo PCNL may require smaller amounts of analgesics, better hemodynamic stability, recovery time is good, decreased blood loss, shortened surgeries, everything is fine. And this is not simply simple. This is 1,200 patients they have done. Feasibility and complications of spinal anesthesia. Only one thing is they say GA provides more satisfaction for the patient and surgeon. There's one thing which I feel is sometimes they want the lung down. It is very difficult in spine. What I do is ask the patient to take deep expiration and then stop breathing for some time. He will cooperate and some amount of sedation is needed, not very deep sedation. He will cooperate as soon as you introduce the scope. This is something like lung down. Safety and efficacy versus in PCNL, they have said surgeon is fine, patient is fine, everything is fine. Patient satisfaction is sometimes better in GA. Less postoperative time, less early recovery, no problems of airway, eye hand injuries, nothing. But can he lie down for prolongs? Breath holding, surgeon comfort. If there is any problem, so my technique is always keep an pro-seal landing and the stretcher by your side. Structure should be easily recoverable. In case of emergency, put pro-seal LME in the prone position. And then in case of emergency, get the stretcher and back. This is what is my technique. I always do. Another thing in regional anesthesia I do is I keep the blood pressure around 120, not to fall like 90 or something like that. I keep the BP 90 plus. Because sometimes if you wait for 90, at the time you take up the BP will be 80 and the patient will start vomiting in prone position, which is a complete cumbersome problem for the surgeon. You will do up and all. The surgeon cannot operate anything. You will start to vomit. So that is better to avoid in all these things. Yes, it is very important that we should know the surgeon. Anatomical structure of the kidney, size and composition of the stones before going out to any type of anesthesia technique. So we have done a lot of prone position surgeries. For example, this was published. This is not related to PCNL, but this is done for major spine surgeries. There are two doses, 4 ml of 0.75% bupivacaine they are given here. Combined spinoepidural can be safely administered. They occupy less operating rooms. Post-operative period is more comfortable. This is not old. This is 2023. We are in 2024. Segmental epidural, an optimal technique. T1, T7 space, epidural catheter, rolled and fixed the opposite side up. So, for example, left PCNL, it should go right side and up, the epidural catheter. As a role in selected patients, short durations, expert. One patient had FG epidural injuries. I use lot of segmentospinal epidural. Now you can see I am in around T9, T10, T10, T11 level. Like 2 ml of bupivacaine with 25 mg of fentanyl, and then put the epidural catheter once above. And if the PCNL is this side, I'll fix the epidural catheter here. And I don't use for postoperative pain relief. I give a local infiltration and remove the epidural catheter because I don't need this. So I just remove those epidural catheters after the surgeries, only for intraoperative top-ups. L1, L2, they have done a lot of percutaneous lithotomy with epidurals. PCNL and severe COPD. The 12th subcostal space was chosen as the puncture spade. Infiltrated. You see total usage for 50 level. Severe COPD, they have done under only local. What I felt after some time, this thing, no, you take an ultrasound and just give the kidney, where is it to the patient? So, surgeon, where is the patient's kidney to the surgeon? Now you can mark the kidney and then give an idea. Also, I will come back again. Now you see here, this is a mid-scapular line, pleura is here. Now your rib is okay. Now this is the kidney where this thing is coming. You can puncture the pleura, 0.3 to 1%. And if you puncture, your airway pressure is going to rise, hypoxia, all these things. Be ready for these things. Especially, here you can see the pleura back, the 12th rib. This is the 11th rib, you can see. 11th rib is here and the pleura is slightly down. Now, this is what I want. If the surgeon wants a supra approach rather than an infra approach, below the costal margin, for the stones to be approached, then there is a danger of pleural puncture. The potential risk is acute hydrothorax, consequent respiratory. We have to find out from the surgeon where is the stone, how is the approach, where is your puncture going to be. Yes, can we show the pre-op ultrasound, where is the pleura and where is your puncture? And that will be very safe. That is what I will suggest. Now we can show the pleura, lung, kidney, liver, everything to the surgeon. Hepatic or splenic injury may occur because sometimes there may be small hepatosplenomegaly. Management of splenic injury, yes. You see the ultrasound report. If there is any organomegaly, very important, left side head. If there is any splenomegaly associated, where is the pleura? All these things anesthetist should know. The nearby organs, colon, can have injuries. Hollow organs, small bowel, colon, may require sometimes laparotomy. Gallbladder perforations can occur and patients will go into septic shock without our knowledge because we did not know. We thought we will think that this is the thing, but the patient will have gallbladder perforation. Now you see biliary peritonitis due to gallbladder after PCNL. Major vascular injuries, hematuria can occur in one person. Persistent hematuria may be very rarely life-threatening. Or also some injuries, some blood will come continuously for a few days. That is not a matter. But major vascular injuries, beware. Air pyrogram. So they want to do air pyrogram. Sometimes they may go on to air embolism. Anomalies or previous surgeries in ectopic kidneys. Now we will go to the postoperative analgesia in PCNL. There are a lot of things. Erector spinal blocks for postoperative pain relief. Intercostal nerve block, but dexterity, we should know where we are, we should know the pleura, everything. Paravertebral block is better than so-called tramadol. And infiltration is always better. So give an infiltration and take it out if you are not good in giving paravertebral blocks. QL is better than infiltrations. So what are the options in postoperative pain relief? Intercostal blocks, plantar spinae, local infiltration, and QL blocks. So if you are good in blocks, yes, proceed with blocks, paravertebral. If you are not good in blocks, give an infiltration, come out with narcotics and paracetamol. So what is this percutaneous nephrolithotomy? We know the indications: lower pole stones, sag on calculus, necrotic kidneys. We should know the renal problems, urine, and where is the site. We have got prone positions and problems because sometimes they will do stenting in supine position and go back to prone again. IV fluids is very important because they will give a normal saline. Extubation, beware, because we are going to have possible chances of any other injuries if they are going in supra approach. Complications, yes, bleeding, major vascular injuries, splenic and liver injuries if there is any spleninovascular enlargement, and if there is pleural injury, beware of airway pressures, hypotension, and hypoxia. All these things have to be monitored because there may be a mild pleural injury which may manifest as hypoxia in the postoperative period. So we should be careful. Take an X-ray if you are any doubt. Put an ultrasound to see whether the lung expansion is fine. We need utmost vigilance because sometimes bacteremia will cause sepsis and postoperatively the counts may increase and there is a mild tachycardia. Patient is taking food. We will miss that post-op sepsis. Thank you and visit me at Pain Free Partha. Thank you all.